If anyone have any question, please ask it at the end of the session. If time permits, speakers will definitely give answer. Now, it's my great privilege to request the chairpersons to conduct the session.
Thank you. Very good morning and Assalamu alaikum to everybody present in this August gathering. It is my privilege to introduce Professor Firoza Begum in front of this session, in front of this audience. Professor Firoza Begum, she is the founder and president of the Maternal Fetal Medicine Society of Bangladesh. She is the ex-chairman, Department of Feto-Maternal Medicine, Bangabandhu Sheikh Mujib Medical University. She is the vice president of OGSB, Bangladesh Society of Medical Genetics. Her special interest is prenatal screening and diagnosis, high-risk pregnancies, infertility management, laparoscopic surgery. She has lots of articles published in different journals, but she is also the writer of high-risk pregnancy for postgraduates. Thank you. May I invite Professor Firoza Begum to come on the dais and deliver her lecture. Thank you.
Respected chairpersons and dear participants, Assalamu alaikum and very good morning to everybody. I welcome you all to the second International Scientific Conference of Maternal Fetal Medicine Society of Bangladesh, and also to my presentation, Inverted Pyramid of Antenatal Care. The theme of this year's conference is Quality Care, the Savior, and this session is on quality care. Yesterday, in our pre-congress, Professor Mahesh mentioned that we are not midwives. Our task is to deliver a healthy baby in all respect, and we should have a healthy outcome of the mothers. And this is possible only with quality care. So I will try to explain the quality of care in my presentation. Dear participants, pregnancy care in the 19th century was confined to the rich people, and it was at the time of delivery only. In the 20th century, pregnancy care was because of the high maternal and infant mortality, it stimulated the development of the institution for antenatal care. We are now in the 20th century, but according to WHO, even today, approximately 300,000 women and adolescent girls die as a result of pregnancy and childbirth-related complications. And around 99% of these deaths occurs in developing countries like ours. And most of these deaths can be prevented. So, antenatal care is a method of detecting high-risk pregnancy and educating mother to have a healthy birth. ANC provides a platform for important healthcare functions, including health promotion, screening, diagnosis, and disease prevention. It has been found that implementing timely and appropriate evidence-based practice, ANC can save lives because it reduces complications from pregnancy and childbirth, reduces stillbirths and perinatal deaths. Now, This is the pyramid of care we are following in most of the developing countries. In this pyramid, you see that women are sent once or twice in the first half of the pregnancy, and there is no rationale or timing and the clinical content of the visits. The high concentration of visits in the third trimester is firstly due to the most of the complications occurs in this stage of pregnancy, and secondly, the most adverse outcomes are not predictable during the first or even the second trimester of pregnancy. This 90 years old pyramid of care has been shifted in 2013. The Fetal Medicine Foundation proposed to shift this pyramid of care, and to aim is to improve the pregnancy outcome through effective screening for the adverse outcome in the first trimester between 11 to 13 weeks, and to improve the outcome by shifting pregnancy care from a series of routine visits to more individualized patient-specific and disease-specific approach, both in terms of schedule and content of such visits, and to introduce effective preventive procedures. Now, what are the contents of such visits? Early screening of fetal aneuploidy, early diagnosis of fetal structural abnormality, early screening of preeclampsia, HGA, and preterm birth, early screening for miscarriage and stillbirth, and detection of chorionicity in multiple pregnancy. Now, what to look for in this first trimester? We do ultrasound assessment to see the nuchal translucency as well as the nasal bone, do some serum analytes like PEPE, pre-beta HCG, PLGF. We do early survey of the fetal anatomy and Doppler study, including the ductus venosus, tricuspid regurgitation, uterine artery Doppler, as well as measurement of the cervical length. Each visit would have a predefined objective, and the findings will generate a likelihood ratio that can be used to modify the individual patient and disease-specific estimated risk from the initial assessment. Now, why do you screen NT? We all know Down syndrome is the most common chromosomal abnormality. Increased NT is related to increased risk of chromosomal abnormality, though it allows primarily to determine the risk of Down syndrome, but it also helps to detect a number of other chromosomal abnormality, including those of trisomy 13, 18, as well as that of fetal cardiac defect. Now, how we interpret NT? At 11 to 13 weeks, when the cranium length lies between 45 to 84 millimeter, NT should be always less than 3.5 millimeter. And here we see, as the value of the NT increases, the risk of chromosomal defect increases. When the NT value lies more than 8.5 millimeter, the fetus has a risk of 75% risk of being an aneuploid. Using NT as the sole criteria for fetal aneuploid screening detects only 3/4% of all fetuses with trisomy 21. But if we combine it with the maternal age-related priority risk, and a detection rate of almost 80% can be achieved. Now, there are certain fetal anomalies that are associated with increased NT. These include major cardiac defect, diaphragmatic hernia, exomphalos, body stroke abnormality, skeletal defect, and some genetic syndrome like adrenal hyperplasia, fetal akinesia syndrome, Noonan's syndrome, Smith-Lupoli, and spinal muscular atrophy. Now, the NT and the cardiac defect. Here we see that when the NT value lies below the 95th centile, the risk of cardiac defect in the fetus is only 0.16%. But as the value of the NT increases, the risk of cardiac defect increases. When the NT value lies more than 6.5 millimeter, risk of fetal cardiac defect is 30%. Now, the nasal bone. A absent or underdeveloped nasal bone increases the likelihood that the fetus has got a Down syndrome, and the likelihood increases as the length of the nasal bone decreases. Detection rate of Down syndrome using the nasal bone alone is only 67%, but when we combined it with NT, the detection rate reaches to 90%. But it requires expertise and strictly following the criteria for measuring the value. And here we see the measurement of the NT and also the nasal bone. Now, the OSCAR. OSCAR stands for One-Stop Clinic for Assessment of the Fetal Risk. And this is the latest prenatal screening program for Down syndrome. Again, it has been introduced by the Fetal Medicine Foundation. It includes not only the measurement of the NT, but also some serum PAPE and free beta HCG. The aim of this OSCAR is not to screen the trisomy 21, but to diagnose number of fetal structural malformation. And in trisomy 21, we all know the serum free beta HCG is twice as high and PAPE is reduced compared to that of a euploid fetus. In the trisomy 13 and 18, as well as in triploidy, both serum beta HCG and PAPE are decreased. And in sex chromosomal abnormality, the maternal serum beta HCG is normal, but PAPE value is low. Now, detection of fetal structural abnormality. Yesterday, we had a very beautiful presentation from the Dr. Daniel from Australia. He has shown that fetal structural abnormality can be detected even at 8 to 9 weeks of gestation. And detectable abnormalities in the first trimester are body stalk abnormality, anencephaly, all over holoprosencephaly, exomphalos, gastroschisis, megacystis, amelia, phocomelia. So the aim of first trimester scan is diagnose or suspect the presence of most major structural abnormality, which is either lethal or associated with severe handicap, so that the parents have the option either to terminate the pregnancy earlier. Here we see detection of fetal anencephaly, fetal gastroschisis, and holoprosencephaly. There we see that fetal spine, this is quite normal, fetal limbs, and monochorionic and dichorionic twins. Now, detection of open spina bifida. Caudal displacement of the brain usually is apparent at 11 to 13 weeks. And the lower part of the fetal brain between the sphenoid bone anteriorly and the occipital bone posteriorly can be divided into brainstem in the front and the combination of the fourth ventricle and the cisterna magna in the back. In fetuses with a spina bifida, the brainstem diameter is increased and the diameter of the fourth ventricle and the cisterna magna is decreased. This is the brainstem diameter. Here, this is a normal fetus and this is a fetuses with a spina bifida. Now, the role of Doppler in the first trimester. In the first trimester, we do some Doppler study like ductus venosus, tricuspid regurgitation, and uterine artery Doppler. Ductus venosus Doppler, in the first trimester, ductus venosus blood flow is an adjunctive test for fetal aneuploidy screening. We know the forward triphasic pulsatile flow is normal in the ductus, but if we see reverse flow at the time of atrial contraction, it is associated with aneuploidy and fetal cardiac defect. Ductus venosus will always have triphasic forward flow. Now, the tricuspid regurgitation. Abnormal tricuspid regurgitation in the first trimester again is associated with fetal aneuploidy and abstrain anomaly. Tricuspid regurgitation is considered to be present if the regurgitant jet is 60 centimeter extending over half of the systole. And this is the normal tricuspid and this is the tricuspid regurgitation. And this tricuspid regurgitation again can be used as a second line screening test after NT and serum screening. And if we combine this with these together, the detection rate for aneuploidy increases to about 92%. Now, regarding the uterine artery Doppler. Uterine artery PI is increased with impaired trophoblast inversion in the maternal spiral arteries. So the aim of uterine artery Doppler at this gestation is to identify women who subsequently will develop preeclampsia. Early diastolic notch indicates increased impedance to flow and should disappear by 13 weeks. If it persists beyond 20 weeks, this woman is more likely to develop, the woman has abnormal vascular tone, she is more likely to develop preeclampsia. Preeclampsia, you know, we can detect from maternal history, but it can detect only 30% of the cases of preeclampsia. and having a false positive rate of 5%. But uterine artery Doppler, if you combine it with history, it gives it improves the pregnancy outcome because we can give some interventions and fetal monitoring, intense fetal monitoring in such cases can prevent the risk of complications. And regarding the interventions, what are the interventions will be given? Actually, it is given aspirin, and we also can give antihypertensive earlier to this woman because we can diagnose early and we can deliver timely. Now, ASPRE trial. ASPRE trial actually is a multi-center randomized trial involving about 26,000 women. And this trial has confirmed that multi-parametric assessment, including maternal risk factors, history and mean arterial pressure, uterine artery Doppler, as well as maternal biochemistry, that is PAPE, PLGF, and inhibin A, at 11 to 13 weeks can detect vast majority of the women who will develop preeclampsia before 37 weeks. And it virtually diagnoses all women who is likely to be affected before 34 weeks at a screen positive rate of 10%. In the screen positive group, it has been found that administration of 150 milligram aspirin compared to placebo has reduced the risk of preeclampsia to 62%. Now, the small for gestational age. Small for gestational age may be due to constitutionally small or growth restricted due to impaired placentation, some genetic disease or environmental damage of the fetus. Combination of maternal characteristics, mean arterial pressure and uterine artery Doppler, as well as measurement of various placental products could potentially identify 75% of the pregnancy without preeclampsia delivering a HGA neonate before 37 weeks. And it will also diagnose 45% of the fetuses who are delivering at term at a false positive rate with HGA at a false positive rate of 10%. Now, early screening for miscarriage and stillbirth. Detection of fetal cardiac activity at 11 to 13 weeks, the risk of miscarriage and stillbirth is around 1 and 0.4% respectively. Here we see that increased NT, reverse A-wave in the ductus venosus, and low maternal serum PAPE is associated with increased risk of miscarriage and stillbirth. Increased risk of miscarriage and stillbirth is also associated with certain maternal characteristics like maternal age, increased weight, previous miscarriage or stillbirth, and some racial origin. Early identification of this high-risk group and can help us in reduction of these complications through closer monitoring and appropriate timing of the delivery. Now, preterm birth. Preterm birth is the leading cause of perinatal death and handicap in children and is the vast majority of mortality and morbidity relates to early delivery before 34 weeks. The patient-specific risk for spontaneous delivery before 34 weeks can be determined by algorithm combining maternal characteristics, that is maternal increased age, high BMI, smoking, assisted reproduction, and previous history of preterm birth. This priority risk can be modified by sonographic measurement of the cervical length. It has been found that risk of preterm birth is inversely related to the increased cervical length. That is, longer the cervix, the risk of preterm birth is less. GDM. Algorithm which combine the maternal characteristics like maternal age, BMI, family history of GDM, along with maternal serum level of low adiponectin and sex hormone binding globulin could potentially identify 75% of the fetus pregnancy which will subsequently develop GDM and with a false positive rate of 20%. So, dear participants, in this new pyramid of care, between 11 to 13 weeks, we can classify the woman as a high risk or low risk. The high risk group can have closer surveillance in a specialist clinic, both in terms of investigations to be performed and the personnel involved in the care of this woman. On the other hand, the low risk group can have another visit at 20 weeks and to reevaluate the fetal anatomy, growth, and reassess the risk of complications like preeclampsia and preterm birth. So, it decreases the our load to see the patients, and also gives benefit to the patient, that is the patient does not need that much visit to the OPD. So in conclusion, I would like to say maternal characteristics, maternal certain serum biochemical markers like PFA, PLGF, pre-beta HCG, and early ultrasound screening with adequate knowledge can prevent the complications of miscarriage and stillbirth, and as well as preeclampsia, HGA, and delivery of preterm delivery. And so I will request from this forum, today I would like to request all and everybody to please invite the pyramid of care that can help our women, that will help our babies. Thank you all.
Thank you, Professor Firoza Begum, for your brilliant presentations. We all know that we are doing antenatal care, that is care during pregnancy, especially to detect. There are lots of goals, but one of the important things is that we want to prevent, detect, and treat any abnormalities of the mother or the fetus. And we are usually doing it in a pyramidal shape. That is, as Professor Firoza Begum has said, and most of the time, most of the gynecologists are doing in that way. But she has shown the importance of inverted pyramidal technique for treating the antenatal care patients, so that we can diagnose the fetal abnormalities. Different types of fetal abnormalities can be diagnosed in the early pregnancies, and if we do not ask them to come once in 16 weeks, then we will lose so many things. And if we see that after doing some basic investigation, if we can see that the problems, she has got some problems, then we will go for further frequent visits. And otherwise, if she has no problem, she will be grouped as a low risk. Though there is now patient is low risk or high risk, but even then there are lots of things which can be dictated by the investigations. So I think this is a very important thing. Though most of us, I myself also, we are doing pyramidal shape antenatal care, but we should go for inverted pyramidal shape care for the antenatal, so that we can reduce the workload of doctors and also reduce the harassment of the patients, and also we can decrease the monetary expense. It will be less expensive, so we can, if we diagnose, and so that we can, at the same time, if we do the inverted T, we can diagnose the complicated cases very early and treat accordingly. Thank you, Professor Firoza Begum, for your brilliant presentations. Your presentation has so many beautiful pictures and slides and also other things, and lots of information for us. Again, I want to thank you all. Thank you. And now it is my privilege to hand over the microphone over to Professor Firdausi Begum. She is the chairperson of this session.
Good morning. Good morning. We just ended a fantastic presentation, very eye-opening one on inverted pyramid of antenatal care. Now, quality of care, equally important. And the presenter of this important topic is Dr. Pooja Lodha. She is the FMF Fellow of Foxy and Fetal Medicine Foundation of UK Certified Association, I understand. And she is the lead consultant, fetal medicine and fetal therapy, Ruby Hall Clinic and Bharati Vidyapeeth Medical College and University. And she is also the director of Kangaroo Cradle, the fetal care clinic of Pune. I think this is a very important intervention, the kangaroo care, which our part of the world is taking up. So,
Thank you.
Here is Dr. Pooja Lodha, and she'll be speaking on quality of care. Thank you.
Thank you, Madam, for the kind introduction. Respected chairpersons, dignitaries on the dais, special gratitude of mention to Dr. Firoza Begum, Madam, and Dr. Tabassum for having me here. And I welcome you all to this Congress, and I bring warm greetings from Pune. This picture was actually supposed to be very colorful, but I think because of the vibrant purples in the audience, it's looking black and white. So it's a beautiful audience here. Good morning, Dhaka. Good morning, everyone, and namaste. I'm Dr. Pooja Lodha, and today I will speak on a kind of an offbeat topic. It's not properly in the curriculum, but there are bits and pieces of things that we do antenatally during pregnancy which improve their neonatal and the infant care, in fact, the adolescent care. So we all are already doing most of this. We just need to channelize the whole process and form protocols for it. So the outline of my presentation today would be antenatal steroids, the changing concepts, the role of magnesium sulfate as a neuroprotector beyond preeclampsia, the placental transfusion, fetal growth restriction, how Dopplers can help in improving the neonatal and infant quality and life care, and multidisciplinary approach, the importance in today's world. So starting with antenatal steroids, we heard from Dr. Mandakini ma'am yesterday, all of those who were there for the workshop, that this is the commonest, the simplest, and the most rewarding fetal therapy that we all have been giving to our fetuses since decades. So a simple administration of maternal steroid can improve the fetal neonatal outcomes hugely. How does it work? It works at the respiratory level and the circulatory level. It accelerates the development of pneumocytes and enhances fetal antioxidant enzymes. What we need to note here is a catch. It does not work at all phases of lung development. So antenatal steroids will only work beyond 24 weeks, once the bronchial tree of the fetus has developed down, branched into the bronchial tree. When embryologically the fetus has already developed the bronchial tree, only then the steroids are going to work. So if you have a PPROM, rupture of membranes at 19 weeks, and you try to give her steroids before delivering her, it's not going to work, because the place where the steroid acts has not yet formed, okay? And therefore, we give the steroids only after 23 weeks. Circulatory, it improves circulatory stability in preterm neonates. It decreases the risk of intraventricular hemorrhage and necrotizing enterocolitis. There's another catch here. Although an optimal dose of steroid and the correctly used steroid in optimal doses reduces the risk of necrotizing colitis, repeated doses of steroids empirically can actually increase the risk of necrotizing colitis. So nothing in excess is good, okay? It has to be in the right dose at the right time for the right purpose when you are sure, almost sure that the lady is going to deliver. So we all know the beneficial effects, and we see that perinatal death tops the list. So perinatal death, neonatal mortality, respiratory distress syndrome, moderate and severe respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and the need for mechanical ventilation is reduced. These are the advantages that steroids give us. So what does WHO tell us? Although it is a 2015 recommendation, it's almost what we have been following. Antenatal corticosteroid therapy is recommended for women at risk of preterm birth from 24 to 34 weeks. So between these gestational ages, when in doubt that the lady is going to deliver, please give the baby a benefit of doubt and give it a shot of steroid. When preterm birth is imminent within 7 days of starting the treatment, including the first 24 hours, is when the steroid should be given. The doses are similar for single and multiple pregnancies. You don't need to double the dose for a multiple pregnancy. You can give it for rupture of membranes. It is a relative contraindication if signs of infection are present. So if there is fetal tachycardia, maternal tachycardia, abdominal wake, lower abdominal wake, pain, fever, you do not give steroids because it will flare up the infection. One of the societies, in fact, ACOG, mentions chorioamnionitis as a contraindication to give steroids, but not rupture of membrane. So there's a difference. If the membranes rupture doesn't mean there is already chorioamnionitis, okay? So if the ladies come with a fresh leak without any markers for chorioamnionitis, you can give steroids. It should be given in fetal growth restriction. There was a misconception that the babies are already small and they have enhanced lung maturity, and so you don't need to give steroids. No, it is not so. You need to give steroids before you deliver a fetal growth restricted baby before 37 weeks. You give it in preeclampsia and diabetes. So yes, we all are aware that steroids will increase her blood pressure, steroids will increase her blood sugar. You still need to give it and monitor the blood pressure and blood sugar. You can admit her and monitor these parameters, but the benefit of steroids is way more than the risks in diabetic and preeclamptic women. So most of the societies and guidelines will recommend the same. And what has changed over all these years, what's something new, is that before 22 weeks, like we saw, steroids are not of benefit. Between 23 and 34 weeks, when in doubt, yes, give steroids. After 34 weeks, till a few years back, it was controversial whether to give steroids or not, because 34 weeks is the mark we talk when there is a pretty good lung maturity to go ahead and deliver the baby, and now our NICUs are well equipped to handle 34-weekers. But something new that has come up is that there is a concept of late preterms. So this concept of late preterm means babies which deliver actually between 34 to 38 weeks. There is early late preterm and there is late preterm, but this whole group has actually benefited from steroids. So in fact, RCOG came up with a recommendation that you need to give steroids to all women for whom an elective cesarean birth is planned prior to 38 weeks and 6 days. Okay? So if she's come in labor and you're doing a cesarean, you don't need to give steroids, because labor itself will enhance steroid release and kind of help there. But if you've planned a cesarean section electively for a diabetic or preeclamptic or whatever reason at 37 weeks or previous 3 cesareans, you need to give steroids. Recently in 2022, I have not quoted it here, it's a very recent recommendation where they say that between 36 and 38 plus 6 weeks, you need to discuss the pros and cons with the couple before you give steroid. Okay, so till 2022 February, this was the guideline being followed. But now they say that you need to discuss with the couple that you could or could not give steroids, and the couple should have the right to know the complications of giving steroids or waiting for those 48 hours before you want to deliver the baby. Okay? In short, between 23 and 34 weeks, when in doubt, give steroids, because our neonatology fellows, our friends, the first thing they're going to ask when you call up to say at 2 a.m. and say we have an emergency cesarean here, they will ask, was the steroid given? When? How many doses are done? Okay? So when in doubt, give steroids. Do not overdo it. There was a practice of giving weekly steroids till the baby delivers. So probably for IVF pregnancies, for mothers who've had previous preterm births, or you think she could deliver, but she isn't delivering week after week, do not give repeat steroids. In fact, repeat steroids, irrespective of whether it is betamethasone or dexamethasone, have their own list of complications. Betamethasone is better studied for repeated dosage complications, and it actually increases the risk of the baby being small or fetal growth restriction. It increases the risk of cerebral palsy, delayed neurological development in childhood, and neonatal sepsis. So weekly repetitive doses of antenatal steroids are no longer recommended. Yes, you can add on a single rescue dose. And what is the indication of this rescue dose? Likely deliver beyond 2 weeks from the first dose. So suppose you've given the first dose as 26 weeks, she came with threatened preterm, but she did not deliver. Okay? And now she's come at 33 weeks again, and now she is in preterm labor and you know she's going to deliver. Please repeat the dose, because it's been more than 2 weeks since you gave it last, plus it is less than 34 weeks. Okay? If the same lady would have come at 36 weeks with signs of preterm labor, you would not have repeated the rescue dose of steroid. So this is the whole balance between the risks of steroids and the benefits we get. And I was pleased to know that most of you here in Dhaka are using dexamethasone versus India, where a lot of centers are still using betamethasone. I was speaking to Sir, even in Sri Lanka, they are using betamethasone. In fact, in Asian countries, it is preferable to use dexamethasone over betamethasone for these reasons. So betamethasone is not very stable at high temperature, as most of our Asian countries have a very high temperature. It has a longer half-life, is more expensive, and it has a larger volume of distribution. Dexamethasone is very stable at high temperature, so suited for our countries. It has a shorter half-life, is less expensive, probably easily available in Dhaka as well, and it has a smaller volume of distribution. Now, why is dexamethasone chosen over betamethasone? All the studies that we've been hearing all these years and the dosage of betamethasone, the trials were done in the Western countries, okay? In Asian countries, the salt betamethasone acetate and phosphate is not available. The studies were done on this chemical compound, but in Asia, this chemical compound is not available. What is available is betamethasone phosphate without the acetate, and this particular compound is short-acting and requires more frequent dosing. So what we are doing in India is something really wrong, and what we are doing is following the West, but the salt is different. So we are not giving enough benefit to the mothers, and therefore we are trying to shift to betamethasone. Betamethasone phosphate schedule is similar to that of dexamethasone without added advantage over dexamethasone. A word of caution here, not many studies have been done on the risks of dosage of betamethasone used for lung maturity. So do not give multiple doses, and please follow up these mothers and babies. It's something relatively new. Coming to the second aspect, one of the most important antenatal interventions to improve postnatal outcome is the neuro savior. Can you guess what it is? Excellent, it's magnesium sulfate. So all these years we've been thinking that magnesium sulfate is to prevent eclampsia, and how this came up is really interesting because we all are aware of the famous MACPI trial, which was to prevent eclampsia, where Maxulf was used to prevent eclampsia. Now, the phase 1 trial told us that Maxulf is really effective to reduce the risk of eclampsia in severely preeclamptic mothers. But the phase 2 of this trial realized, looking back at the numbers, that the mothers who had severe preeclampsia and received Maxulf to prevent eclampsia, the babies are doing better than the preeclampsia mothers who had moderate or mild preeclampsia. The babies are not doing as well. And then they went back to realize the only factor that made a difference was the administration of Maxulf. They did not primarily do it for neuroprotection, but they realized over a period of time that yes, it is Maxulf which is helping these babies cope better in life. Over the last 5 years or so, most of the international guidelines and organizations and groups have supported the use of magnesium sulfate for neuroprotection. In fact, Cochrane, which rarely comes to a consensus, also tells us that magnesium sulfate is recommended for women at risk of imminent preterm birth before 32 weeks of gestation for prevention of cerebral palsy. WHO 2015 also regards this as a very strong recommendation. In short, there is really no two thoughts about magnesium sulfate being used if a lady is delivering before 32 weeks. So, to whom and when to give it? Give it to women with imminent preterm birth and less than 32 weeks. So, it acts from viability to 32 weeks. Viability may change from country to country. It can change from city to city and villages. If suppose your viability cutoff is 27 or 28 weeks, if your NICUs can manage that, that is your viability, okay? So depending on what your stage of viability is, up to 32 weeks, please give Maxulf before delivery. So a lady has come in threatened preterm at 30 weeks or 29 weeks, and you're giving her Maxulf, you're giving her tocolysis to prevent the labor pains, to kind of stop the preterm labor, and you wish that she prolongs this pregnancy further, Do not add on Maxulf with that. In short, Maxulf is not like steroids. You don't need a window for it to act. You don't give it empirically. Okay? Maxulf is to be given only when you are sure you are stopping the tocolysis, which means you are sure you're going to deliver her, or you are sure that she is going to deliver any which way. So that's the difference between steroids and Maxulf. You can't just give it. What is the dose? This is something easy for all of you and for your nursing staff and everybody. If you don't remember the complicated doses, remember the dosage is same as that to prevent eclampsia. So you give a 4-gram IV loading dose over 30 minutes, 1 gram per hour maintenance infusion till birth, or 24 hours, whichever is earlier. There are various regimens. This one's simplest to remember and works well. So if you have a planned preterm elective cesarean tomorrow morning because of her shooting high blood pressures, if you want to give her magnesium sulfate for neuroprotection, the optimal time to do it is 4 hours prior to the cesarean. So you don't give magnesium sulfate and wait for 2 days for it to act. You give magnesium sulfate and deliver in the next 4 hours. Okay? If she's come in labor, which you're not able to even prolong for another 4 hours, even if you give Maxulf in the labor room, in the emergency units, and you shift her to the OT, it's fine. It's going to work. So give it now and you deliver in half an hour, it's going to work. Okay? So when in doubt, when the lady is delivering, when she is less than 32 weeks, give Maxulf in the dose mentioned. Delivery should not be delayed for Maxulf. She is delivering, she is having contractions. You know you have to take her up for a cesarean. She's previous 2 cesareans. Do not wait for Maxulf to act. It's going to act any which way. So go and deliver her. So very important is communicate with your fellow neonatologists. Okay, when you're giving a dose of Maxulf, please talk to the neonatologist. And why so? This is already a high-risk pregnancy. The baby is already probably very premature because it's less than 32 weeks. The neonatology team is going to be handling the immediate consequences and morbidities of a severe preterm and probably a very small baby. To add on to that, if the baby is limp, if the baby is hypotonic at birth, it will add on to the chaos and trigger a sequence of events which could be unnecessary if you don't explain that, if you don't convey to them that you have actually given Maxulf. Okay? So like in the mother, in the fetus too, in the baby too, in the neonate too, the Maxulf is going to cause depression. It's going to cause depression of respiration and all the consequences that we know of. So please communicate so that they are aware this is going to reverse itself. So MAGPIE trial follow-up said the same drug, the same dose with double benefit. And that's how we come to the neuroprotection there. Now, optimal cord clamping. In 1801, Charles Darwin, who had the theory survival of the fittest, very rightly said, another thing very injurious to the child is the tying and cutting of the navel string too soon, which should always be left till the child has not repeatedly breathed, but till the pulsation in the cord ceases, as otherwise the child is much weaker than it ought to be, a portion of the blood being left in the placenta, which ought to be in the child. So if you cut the cord too soon, if you clamp the cord too soon, you are depriving this baby of blood that it should have had, which belonged to the baby. Okay? And it's very simple. You just need to wait for another 1 minute and the placenta is going to transfuse the baby itself. You don't have to do anything. So delayed cord clamping, which is actually now called optimal cord clamping, means it is a birth practice where the umbilical cord is not clamped or cut until the pulsations are ceased. And usually it could last up to 2 to 3 minutes. You could customize depending upon the situation. So if it is a very, very small baby, if it's like a 700 grammer, you don't need to wait for 2 to 3 minutes because you know too much transfusion would then happen from the placenta to the baby. But mind well, guidelines have said that even in preterm babies, even in fetal growth restricted babies, wait at least till 30 seconds. Do not clamp the cord before 30 seconds. So that much of blood volume will not be detrimental to the baby. We see how very well that the more we wait before we clamp the cord, the pinker the baby gets. And that's how you're just helping. Watchful expectancy, do not touch. It's just happening on its own. And this baby, which was actually receiving just 15 ml within 15 seconds after delivery, if you quickly clamp the cord and in a hurry to give the baby to the neonatologist, would actually receive 30 ml more blood, which means a lot for this tiny baby, okay, if you wait for 60 seconds after delivery. So we have this list of short-term and long-term fetal and maternal advantages if you're doing a delayed or an optimal cord clamping. But the most important long-term one is that it improves the hemoglobin of this infant 10 weeks after birth. So that's how long the effect is going to be. It's also known to reduce the postpartum hemorrhage in the mother. It's known to improve the neonatal complications, the immediate ones as well. So ACOG, RCOG, and the WHO have given these guidelines who say that, yes, you recommend a delay in umbilical cord clamping in vigorous term and in preterm birth as well, lasting up to 30 to 60 seconds. They also mention that you should advocate the documentation of timing of cord clamping. So in your birth notes, apart from how she was delivered, you did a vaginal birth, you did a cesarean birth, please mention that the cord clamping was done 45 seconds after birth, 2 minutes after birth. It gives the neonatologist an insight of what is going to happen further and could help him or her to counsel the couple. Coming to one of the last concepts of how to improve the neonatal infant, in fact, the adolescent outcome using Dopplers. Dopplers has changed. It has really colored our lives. And from the time when there was a very high risk of intrauterine fetal demises, stillbirths, we came into an era where the babies were being saved, but there was a very prolonged NICU stay. So we realized that very good NICU, let's deliver at 28 weeks. So an obstetrician's job, we think, ends when we clamp the cord. The baby cries, win-win. No. Does the baby walk back into your OPD after 10 years of you delivering the baby is your win-win. So when you hand over this baby to the neonatologist at a very early gestation, they do survive because there are excellent ventilators and ECMO and everything happening in the NICU. But at the cost of what? Is it an intact survival? So this was the phase probably a decade back. And we have now come to a situation where despite the NICU being excellent, we don't hurry to deliver because it is 28 weeks already. We wait for the Dopplers to go wrong till a stage where there is not going to be irreversible damage to the fetus, and then we deliver the baby. So there is a balance between delivering too early and too late, okay? We called it intrauterine retardation. Then we wanted to get away with the word retardation, so we called it restriction. And now we give special importance to this fetus and we call it fetal growth restriction. It's no more IUGR, it is FGR. And your victory is when this baby is fine 10 years from birth, 20 years from birth, and in adolescence. Okay? There is no treatment for fetal growth restriction. We all know it. All these amino acids, admissions, Hermine, etc., is just to pacify the patients and ourselves. What is working is your surveillance and optimal delivery decision making. This is the only thing that's working, okay? So how do you do this close surveillance? Sorry, I'll get away with this. So when you have a small baby with abnormal Dopplers, you call it a pathological fetal growth restriction. And when you have a small baby with normal Dopplers, you call it a constitutionally small baby. We have a whole session on FGR later today. But just to touch upon the Dopplers, I started this. Now just try to understand this vessel. This is the umbilical artery. This is the umbilical cord that is connecting the baby and the placenta. There are 2 arteries and 1 vein. The artery carries blood from the baby through the cord into the placenta. Okay? So when you measure this vessel, what are you measuring? Not the baby's condition. You're measuring the placental condition. Okay? This is a very good Doppler of umbilical artery because the baby is healthy, but the placenta is very healthy. It is not providing any resistance for the blood flow into it, okay? Now imagine that there is severe preeclampsia and the placenta is started getting calcified or damaged. Although the baby is fine, it's not going to be able to pump blood freely into the placenta. Baby is trying to pump, but the placenta is not able to receive it as well. And this starts the worsening of umbilical artery Doppler, as you would see in the waveform here. So can you see the difference in the diastolic flow for all of those whom you scan? So you see that the blood is no more going very freely to the placenta. The baby is fine, but the placenta is now getting more and more damaged. Further damage, and there is no end diastolic flow. This is what we call as absent end diastolic flow. And a time comes when there is so much of placental resistance that instead of the baby throwing in blood to the placenta, all the dirty, hypoxemic, acidotic blood comes back to the baby. And this is the stage of fetal acidosis, fetal hypoxemia. And this is what is going to cause probable, irreversible, significant consequences to the baby later in life. And I put this up because we need to understand the importance of Dopplers. Okay? So umbilical artery is one such vessel, the Doppler of which is so important that it is going to have consequences for the rest of the life. So it is a brain time. The perinatal period is the brain time. Dr. Mahesh sir yesterday said what we do in the in the 9 months of pregnancy decides what happens to you in the 90 years of your life. And this is what contributes to all of that. Now these studies prove that umbilical artery abnormalities and delivery, this correlation, this balance you maintain between delivering too early and delivering too late so as to pose the baby to a risk of intrauterine fetal demise, has brought in so many studies. Until the adolescence, we see that babies with absent end diastolic flow in the umbilical artery did not perform well even in the adolescent stage. So that's how important it is to deliver these babies before there is reversed end diastolic flow. You have to deliver these babies before that. Coming to the last slides, it is the optimal delivery decision making. This is going to impact the postnatal life of the baby. And as we see here, we don't want to deliver them too early just because we have a good NICU. And that is because up to 34 weeks, every day in utero improves the life quality of the fetus, its chance of survival by 2%, which is a lot. So delivering at 31 weeks versus delivering at 32 weeks is a difference of 14%, huge. Okay, so before 34 weeks, think twice before you wish to deliver this baby, not just for its survival, but for the intact survival. And why do we consider 37 weeks as an optimal time to deliver all these high-risk women? So, diabetic on insulin, severe preeclampsia, ANA positive, previous multiple losses, IVF pregnancy with comorbidities. Why is the 37 to 38 weeks so important? We don't want to take them till 40. We don't want to deliver them 34 unless there is a problem with the mother or the baby. If everything's going fine, we choose this time which favors delivery statistically because the statistical benefit of delivery at this gestational age outweighs the risk of continuing the pregnancy, the risk of sudden IUFT, the risk of the risk of fetal hypoxia, acidemia. So after 38 weeks, if you want to continue a high-risk pregnancy, you've got to be really cautious because you are not giving that much of a benefit to this fetus as you are putting it into a risk. Optimal delivery decision especially holds true for Bangladesh, for India, for all of us here. Do not try to deliver these high-risk pregnancies in your setup and then shift the baby. It's the first 1 hour which is the golden hour for the fetus. Okay? Try to do an in utero transfer. Talk to your colleagues. Take panel attachments to wherever you want. You go and deliver these ladies, but in a tertiary care where there is immediate baby help available. Do not try to deliver yourself and then transfer saying that I have an ambulance. No, you are anticipating the need for resuscitation, the need for any kind of help for the baby. Please shift and then deliver the baby. And last but not the least, and the most important is we all got to work together. A teamwork will actually make our dream work. The dream of Firoza ma'am, the dream of quality care, the savior. You cannot do it alone. I cannot do it alone. It is the obstetrician, it is the radiologist, the fetal medicine specialist, the geneticist, the neonatologist, pediatrician, pediatric cardiologist. All of us got to do it together. It's not one who can do it alone. So when you are delivering high-risk cases, brief the case to the neonatologist. Don't just rush in for the cesarean and hand over the baby. You need to give a background. There has to be a resident or a doctor assigned to communicate the case to the neonatologist before you are delivering. They know what to expect. ANC, was it eventful? Was it uneventful? Did the lady have problems? Did she have a TSH of 34 when she conceived? They got to do the the TFTs, the thyroid function test of the baby on day 3, day 7, they got to monitor this baby. What is the exact gestational age? Don't tell them by dates, by LMP, by gestational age. No, we only don't understand. What will they understand about all this? Tell them properly. This is a 34-week gestation. You have corrected the dates yourself and then told them the right gestation, because for a neonatology colleague, 34 and 37 are very different. They don't care about your delayed conception. Tell them the correct gestational age. Give steroids. Do not overdo it. Doppler change is extremely important to guide your delivery decision making. Cord blood pH, something very simple. No, we cannot do too many things at Dhaka, I understand. But a simple cord blood pH doesn't cost too much, helps a lot. For a small baby with Doppler changes, for a fetal growth restricted baby, when you are doing this delivery, when you collect the cord blood to do the blood group, etc., please also send it for cord blood gases. Because if there is already acidosis, then it will help our neonatology colleagues to counsel the couple accordingly. You don't give them starry pictures. No, your baby is going to be fine. We have an excellent ICU. What was the pH when the baby was born? There were Doppler changes there. Okay? So work in conjunction with the neonatology colleague. Explain the maternal morbidity and medications. Yes, she was on aspirin. Whatever the mother has been going through, which was eventful in the antenatal period, one resident has to be assigned to talk to the neonatologist. And the blood group, extremely important. Unless you do not communicate that, they may really overlook it. So it's better to do it, go through it twice rather than just keeping it to yourself, because it's not helping. You are handing over the baby, but there's still an overlap of care there. Okay? So I think that brings me to the end of the conversation. Sorry if I overshot the time. Thank you for a very patient listening. Thank you very much.
Thank you, Dr. Pooja, telling us about the quality of care in neonatology. I think in the intrauterine life, we noticed your body language. I think marvelous body language. So you are not only speaking with your mouth, it was your whole body and mind speaking together. Fantastic. Now, what she has touched upon, there are 4 things which she included in the quality of care. And I understand here, with quality of care, she means standard of care. And that we need to maintain for every treatment of every patient. So she touched upon antenatal corticosteroid. Nobody can deny the importance of it. But it has to be optimal. That is very for sure, because if you do too little, that is harmful. If you do too much, that is also harmful. So for the general audience, I think she gave a very clear-cut message. Antenatal corticosteroid start after 24 weeks and till 34 weeks. This is beyond doubt, but our national protocol says, and also the WHO says, that you have to have the neonatal resuscitation facilities available at the center where you are giving this. And the clear message is, I think she didn't touch upon the doses, or I have missed it. It's 6 milligram dexamethasone use 12 hourly, 4 doses. And single dose is better. Sometimes we can use rescue dose. But the thing is, we have to be very precise and clear-cut using, because there are very many evidence that it's sometimes harmful to the mother and the baby. Regarding Maxel, this is uncontroversial. To prevent cerebral damage of a preterm baby before preterm birth, Maxel, in the usual dose we use for eclampsia, is beneficial. And she then touched upon the optimal cord care. And I think this is in our national protocol as well. We delay cord clamping for at least 60 seconds. Our national protocol says 1 to 3 minutes before clamping the cord. And that gives, of course, not only several benefits, including prevention of newborn and adolescent anemia. And finally, she has touched upon a bit sophisticated thing, which is Doppler. And this, we know, this is evidence-based. This and Doppler study is so much give us too many informations for especially the term pregnancy where there is fetal growth restriction, and it was vividly, elaborately presented with evidences. So we have so many quality of care information from Pooja, and thank you, Pooja, for elaborating this. Thank you so much.
Thank you, madam, for conducting this session nicely. And due to time constraint, we cannot take any question from the audience. Sorry for that. Now this is we are at the end of the session. Now I would like to request our chairpersons to give the certificate of appreciation to our speakers. Now I would like to request Professor Anora Begum Madam to give the certificate of appreciation to Professor Firoza Begum Madam. Now I would like to request Professor Firdausa Begum Madam to give the certificate of appreciation to Dr. Pooja Lodha. Now I would like to request Professor Anora Begum Madam to give a book recently published by JP Brothers, written by our Professor Firoza Begum Madam on high-risk pregnancy, to Professor Firdausa Begum Madam. Professor Firdausa Begum Madam is requested to hand over the book to Professor Anora Begum Madam. With this, our session will come to an end. Thank you, participants, for being with us. Stay safe.
Assalamu alaikum. Honorable participant, distinguished guest from home and abroad. Very good morning to all. Assalamu alaikum. I am Dr. Khandaka Shehnila Tasmin.
Hi, and I am Dr. Naushafrin Choudhury.
As rapporteur, welcome you all on today's second session of our second International Scientific Conference organized by Maternal Fetal Medicine Society of Bangladesh, September 2022. Our current session is on prenatal testing and diagnosis, which is an attention-grabbing issue, an integral part in our journey with high-risk pregnancy management. As no pregnant women are free from risk of carrying a fetus with chromosomal abnormality, so prenatal screening should offer in all pregnant women, and it is an integral part of antenatal care nowadays.
We are honored to have Professor Fatima Ashraf as our chairperson, former head of Department Ops and Gynae, Shahid Sohrabdi Medical College Hospital, and ex-chairperson, Public Health Foundation of Bangladesh. We are delighted to have our another chairperson, Professor Shahanara Choudhury, former head of Department Ops and Gynae, Chittagong Medical College Hospital, and ex-president of Chittagong OGSP. I humbly requesting to both of them to please come up on stage and have their seats. Dear audience, in this session, we have two eminent speakers, Dr. Shima Thakur and Dr. UDP Ratnasri. Each speaker will get 20 minutes time for their presentation, and speakers are humbly requested to please complete their session in time. If anyone have any question, please ask them at the end of the session. If time permits, our speaker will definitely give answer. Now, it's my great privilege to request our Honorable Chairperson to please conduct the session. Thank you.
Thank you. Now, I would like to request our first speaker, Dr. Shima Thakur, to present her topic on non-invasive prenatal testing, recent updates. Dear audience, let me introduce Dr. Shima Thakur with you. She is the senior consultant in the Department of Genetics and Fetal Medicine, Fortis Hospital, Delhi, and Rainbow Children Hospital, Delhi, in the Genetic Clinic, Dharka. She has a special interest in genetic and genomic counseling and prenatal diagnosis. She is the current chairperson in AOGD, Genetics and Fetal Medicine Subcommittee for the year 2021 to 2023. She is the vice president, DGF, Dharka, in the year 2021 to 2023. Dr. Shima, please present your paper.
Yeah. Good morning, everyone. I bring for all of you greetings from India. I'm from Delhi, and I'll be talking today about the cell-free fetal DNA, the recent updates, the one actually who has been, the test which has actually changed the, the practice of obstetrician to a significant degree. And I'll take you through the common questions in the clinical scenario, which will help you to understand this very important test for you. So there are 10 clinical scenarios because I work very closely with the NIPT test. So there are basically 10 clinical scenarios which an obstetrician needs to understand. First is the clinical utility of anti-scan in the era of NIPT. So what is the clinical utility? And what is the cutoff for fetal fraction? Can NIPT be used as a first screen test? Should we order genome-wide NIPT? Can we do NIPT with microdeletions? Cell-free DNA in raised nuchal translucency? Can this be applied to the twin pregnancy as well? Should we be disclosing the incidental NIPT results which suggest the maternal cancer? Should we be doing CVS or amniocentesis if the NIPT is positive? Or is there a way for NIPT for thalassemia? Has the time come yet? So I'll take you through the evidence from the literature to support all these evidences, all these clinical scenarios, so that you can decide. And some few cases based on the singleton, twin pregnancy, and the microdeletions. So the spectrum of congenital disorders, this is wide, and this includes congenital malformations, copy number variations, chromosomal abnormalities, and monogenic disorders. And the NIPT detects about 10% of the chromosomal abnormality. Ultrasound detects 50% of the chromosomal abnormality. So you can say that, unless if you want to prevent the mental or the physical handicap, you have to be well versed with the ultrasound. And NIPT also contributes to a significant extent. 10% of the abnormalities which will lead to the mental or the physical handicap can be covered by the cell-free fetal DNA. So just a basics, what are the options for prenatal screening for Down syndrome and trisomy 18? We have integrated prenatal screening. Actually, this is the best, but this cannot be implemented in a country like us. So we are best suited with the first trimester prenatal screening by the dual screen, which includes PAPE and free beta HCT. And in some of the countries, the PLGF and the alpha fetoprotein and the second trimester markers have come up into the first trimester, and which is known by the name of the enhanced screen. Then in the second trimester, we have the quadruple test. And the, above all, it is the cell-free fetal DNA, which has the maximum detection rate. So NIPS, it is a new era in the prenatal screening. In recent years, a new prenatal test has entered the market, and this has rapidly changed the prenatal testing paradigm. Non-invasive prenatal testing, this offers an intermediate step between the serum screening and invasive diagnostic testing. This has become a standard of care in many of these, as a secondary screening in many of the countries. So the NIPT is a secondary screening, being used as a secondary screening as a standard of care. It is a follow-up non-diagnostic test offered to a population that has already been found to be screen positive, that is the high risk, as a result of the previous screening by dual marker or the ultrasound, and commonly used as a secondary Down syndrome screening test because of the highest sensitivity, in the field of screening. This is the test which has got highest sensitivity and specificity to the tune of 99%. And this leads to the reduction in the number of the invasive diagnostic procedure, what a clinician would want. And gradually, when we are going more evolving, we are moving towards the non-invasive. So why this is so important? This can be easily offered to the pregnant woman from a simple blood test. This has got the highest detection rate which we can ever imagine, and very low false positive rates, highest positive predictive value, and above all, this is non-invasive. So the cell-free fetal DNA, this is derived from both the mother and the fetus. Fetal DNA is derived from the placenta, and maternal DNA is derived from the hematopoietic cells. Since the fetus and the placenta originate from a single fertilized egg, they are usually genetically identical, and this is the science behind the cell-free fetal DNA, that the fetus which sheds its material into the maternal plasma, and we are exploiting those fetal cells to detect on the cell-free fetal DNA for the common aneuploidies. And the test includes the 5 common aneuploidies: trisomy 21, 18, 13, and sex chromosomal abnormalities. And recently, there are labs coming up with the rare autosomal trisomies, or you can say the genome-wide NIPT, and also the microdeletions and duplications have been introduced into the cell-free fetal DNA. This is a paper by the Bianchi et al., and she has spoken about the 10 years of NIPT in a recent article in Prenatal in 2021, and she says that it is now 10 years since the analysis of the cell-free fetal DNA, because the cell-free fetal DNA became commercial in 2011. So this is a 10 years since the analysis of cell-free fetal DNA in the maternal blood was introduced clinically as a highly specific and sensitive screening test for the fetal trisomies. Initially introduced in Asia through the commercial sector, in the high-risk pregnancies, NIPT has now been implemented across much of the globe in both the public and private health sectors, with the potential for the expanded indications. So this is the graph which has been given in that paper, and we can see that it started here in the commercial applications, and now there is an implementation for this in the public sector as well. So the NIPT has expanded very rapidly after the introduction, So after this, the ACOG practice bulletin in 2020 that says that the prenatal genetic screening, serum screening with or without nuchal translucency, or the cell-free fetal DNA screening and diagnostic testing option should be discussed and offered to all pregnant patients regardless of the age or the risk for the chromosomal abnormality. So the cell-free fetal DNA, you can be offering as a universal as well. This may, so it has to be offered. So we all know that the cell-free fetal DNA should be offered universally, or at least in the high-risk women. But at the same time, as an obstetrician, it is your responsibility when not to offer such an easily available test, when the first trimester risk is high. Like if a lady has a dual marker risk more than 1 in 50, 1 in 10, 1 in 2, this is not the ideal test. If the PAPA is low, 0.2 mom, beta HCG is low, 0.2 mom, or beta HCG is high, more than 5 mom, then we should not be offering the cell-free fetal DNA. If there are fetal abnormalities like congenital malformations, cardiac abnormality, raised NT more than 3.5 or greater than 99 centile, or there is absent nasal bone, echogenic bowel, we should discuss the option of the invasive and as well as the, options of the invasive to these women. If this is more than, twin pregnancy, NIPT is not yet validated in more than twin pregnancy. Of course, the research is on, and probably in the next time when I'm here, probably I can talk about the triplet and quadruplet rate. But till now, it is only restricted to singleton and the twin pregnancy. In the vanishing twin, this is a relative contraindication, I feel, because of the chances of the high false positive rates. If you have done the fetal reduction or blood transfusion is given, then you should not be doing it. After bone marrow transplantation, and also the malignancy in the mother is a relative contraindication if you know it. What is the most ideal time to do the NIPT? We have just heard that the inversion of the pyramid of care by Professor Firoza Begum ma'am, and we all know that this has to be done in the first trimester itself. So the most ideal time to do is after the NT scan, but we can still do till the 17 to 18 weeks. And the rationale behind defining this timeline for is that in clinical practice, the second trimester, after 20 weeks, generally the termination will become difficult for the mother as well as the clinician. So what is the evidence for NIPS? This is the meta-analysis which included 35 peer-reviewed studies, and this is the most important studies as far as the NIPT evidence is concerned. And they have taken the studies included from January 2011 to 2016 by Gill et al. And this appeared in the, this was published in the White Journal. And we can see here that the detection rate of trisomy 21 is 99.7%, and very low false positive rate, 0.04%. Trisomy 18, 97.9%, and the very low false positive rate of 0.04%. Trisomy 13, 99%, 0.04%. Even the sex chromosomal abnormality. And the last here you can see for the trisomy 21 also, this is 100%. And of course, the numbers are limited. They have sent almost, the false positive rates. So why the test is so popular? Cell-free fetal DNA has the highest positive predictive value, and maybe up to 75 to 80% for the trisomy 21, and very few false positive, hence less invasive procedure. So we can see here that the trisomy 21 by the standard screening, 4 to 5%. For trisomy 18, it's little higher. But see the cell-free fetal DNA, the positive predictive value is about, of course, usually around, varies from age to age, but usually we count around 75%. So coming to the first question, we selected 10 questions for you, which will be of utility for you in the clinical practice. So clinical utility of NT scan in the era of the NIPT. And this is a consensus statement by the ECOG, updated consensus statement on the impact of the cell-free fetal DNA aneuploidy testing on the screening policies and the prenatal ultrasound practice. And this was published in 2017. And they say that all women should be offered the first trimester ultrasound scan according to the ECOG guidelines, regardless of their intention to undergo the cell-free fetal DNA. So you have to do a basic ultrasound scan, there is no doubt about it. But after the NT scan, you can give them 3 options. One is the combined first trimester screening, which will divide the women into the low, intermediate, and high risk. Then you can also offer them NIPT as a first-year test, or they can directly go for invasive testing. So we can, this is the paper which says about what is the role of. So this is a case, NIPT positive for trisomy 21. NT was more than 3 millimeter, that is the 99th centile. And she came for genetic counseling, that what is the implication. So we discuss about that there is a risk for the aneuploidy, there is risk of the cardiac abnormalities, there is a risk for genetic syndromes. And based upon the genetic and the options discussed were invasive versus the non-invasive testing. And she was very sure that she wanted the non-invasive prenatal testing, but because this was attractive to her, there was no risk involved. So we did the NIPS, and the test came as positive. Fetal fraction was 15%. So whenever you have a cell-free fetal DNA or NIPT report, see the report that whether there is any high risk or low risk, and also look at the fetal fraction that gives us that whether the test perform is accurate. So while doing so then after the NIPS is positive, you have to always confirm by the amniocentesis. So we did the amniocentesis, And while doing this, we can see here, this was the NT in the first trimester when she first came to me. But while doing the amniocentesis at 16 weeks, you can see here the prominent nuchal fold, echogenic bowel here, and here the echogenic focus. So these are considered soft markers for the aneuploidy, and with the NIPT positive, this confirmed the FISH was done. You can see 3 signals here for the trisomy 21, and FISH and culture that confirmed that this is trisomy 21. Now the second question always asked is, what is the cutoff for the fetal fraction? Most of the labs would keep changing their fetal fraction cutoff. So what is fetal fraction? Fetal fraction is the percentage of the total maternal plasma that is of the fetoplacental origin. So the fetal fraction is fetal cell-free DNA divided by fetal cell-free plus maternal cell-free fetal DNA. So it is a function of both the maternal and the fetal cell-free DNA. And fetal DNA is actually placental. Between 10 to 20 weeks of the gestation, the average fetal fraction is about 10% to 15%. The standard cutoff for the fetal fraction is being used currently is 3 to 4%, but there would be labs which will be giving you the results even at 1%. So in all these cases, you should call up the lab and re-verify that if they are confident with their results. So what are the causes of the low fetal fraction? It could be gestational age. You could have done at less than 10 weeks of gestation, or your mother is obese, because when the mother is obese, there is huge amount of plasma and the cells get diluted, so there will be less fetal fraction. In the cases of IVF conception, the fetal fraction is low, and in twin pregnancies, the fetal fraction is usually low, and you put most of the women in the low molecular weight heparin, and that also can lead to the low fetal fraction. We had a case which was of lupus anticoagulant positive, and twice we did the cell-free fetal DNA, it failed. Then we changed the technology to the Illumina platform, and that gave us the result. So it was then when we read up the literature, and we found that it was the low molecular weight heparin which can cause. So this is a recent paper by, again, the Bianchi et al., and which says, what should a clinician know about the fetal fraction? So the American College recommends that all laboratories should establish and monitor the analytical sensitivity and validity for the fetal fraction, and they should include a clearly visible fetal fraction. And ACMG also recommends that all laboratories should specify the reason for no call when reporting the non-invasive prenatal screening result. So whenever there is a no call, you call up the lab and ask them what was the reason, because ideally they are supposed to write. So in this paper, they say that there is no universal fetal fraction threshold that should be applicable across all the platforms. And there has not been any differences demonstrated in the NIPT performance by sequencing method or the platforms. So when the fetal fraction should be routinely used, but there is not a consensus. So what should a clinician know? The clinician should know what to expect from a standard test report, and whether the reason for failed NIPT has been revealed. So as a role, of course, you have to look at the fetal fraction, but you should also know the reason that why the fetal fraction is low. Then we have evidence for, can NIPT be used as a first-year screening test? And this is a study in Australia. This was a retrospective study of women residing in the state of Victoria, Australia, who underwent the prenatal screening or the invasive prenatal diagnosis in 2015. And during this period, about 79,140 births and 66,166 women, they underwent at least one form of aneuploidy screening. And you can see the pattern of screening is very similar to us. They did the combined first trimester in 73%, only cell-free fetal DNA in 20.2%, and second trimester screening alone in 5%, and cfDNA plus combined first trimester 1.3%, and second trimester plus cell-free is in the less. And they found that the sensitivity of the CFTS, that is the combined first trimester, is 89.5% at the false positive rate of 2.94, and cell-free fetal DNA has a sensitivity of 100% and with a screen positive rate of 1.21%. And the residual risk for any chromosomal abnormalities after a low risk from the CFTS was 1 in 1188 and 1 in 722 for cell-free fetal DNA. So you can see here, so far they are okay only. But what was the the biggest difference in this study which has been shown that the false negative in the combined first trimester, the one which included that comprises 10 cases of T21, one of the T18, and one of these are all common aneuploidies. But in the cell-free fetal DNA, it was the pathogenic copy number variants, triple RD, the rare autosomal trisomies, monosomy X. So these could not have been picked up, otherwise in the routine combined first trimester screen. So there, you cannot be excused for, missing a trisomy 21. So the sensitivity is same, and it's only that the pattern of abnormalities picked up or missed during the combined first trimester is the common aneuploidies, and we should be, we are responsible for that. So this is a paper by the position statements for all the societies, and this is also a recent paper. Here they have used 21 statements were identified between March and till March 20, and you can see the latest guideline is 2019, and the professional societies, the paper concludes like this, that the professional society guidelines provide valuable direction to the healthcare providers, especially in this era where there is a rapidly evolving evolution in the genetic testing, and we encourage the updates from the professional society, the quick updates to existing recommendations to reflect the growing body of evidence. So we can see here that even the fetal fraction 71% did not agree. Of course, everybody agrees that the NIPT is an accurate test, diagnostic confirmation is required, but whether microdeletion should be included, whether sex chromosomes should be included. So the current updates are required. That's what we expect from them. Now the next question is, should we be doing, so we have done universally, we have found the evidence that this is better. Now what should we be doing? Should we be doing only 5 chromosome, or we can use the genome-wide NIPT? Till now, I also mainly do the 5 chromosome aneuploidy only, and this paper, this says that there is a paper from Netherlands that the trisomy 21 accounts for 53% of the cases, trisomy 18 13%, and 13 is 5%, sex chromosome 12%, and other chromosomal abnormality, they account for 17%, so not a small number. And this is a paper from Netherlands and by the name Trident 2 study, where they have done national implementation of the genome-wide NIPT as a first-year screening test in the Netherlands. And they say that Trident 2 NIPT and rare autosomal trisomies was identified in 0.18%. Positive predictive value is very, very low, 6%. Structural chromosomal abnormality, 0.16%, but positive predictive value is 32%, not bad. And abnormality suggestive of cancer is 0.02%, positive predictive value is high. So this was in 2019. And to support their feeling that, this can be used genome-wide, they tried to improve. And in the 2022, just today I came across this paper, and this is one of the clinical impact of genome-wide NIPT. And in this paper, they found that clinically significant 0.36% of the cases, which included about 358 cases out of 110,739. And they conclude that this genome-wide application, so this provides an evidence for genome-wide applications. Now, should we be doing NIPT with the microdeletions? So what are the microdeletions? The Cri-du-Chat syndrome, the Prader-Willi syndrome, the 1p36 deletion syndrome, 22q deletion syndromes, and 22q deletion is common, 1 in 4,000. Last year I came across 2 children with 22q deletion, and they are coming with the mild learning disability. So should we be doing it? And this is a study, again very recent study, 21 centers, 6 countries, 20,887 women, and 12 cases of 22q deletions were identified, and 9 of 12 cases were detected. So the detection rate is 75%, specificity 84%, positive predictive value not bad, 23%. We compare with the Down syndrome dual marker, it is 4 to 5% only. So it's quite good. Then professional societies do not recommend the routine use of the expanded NIPT for the microdeletions. So the ACOG, SMFM, the ESHIOG, the Australian Society, and this is why they don't support the challenges of achieving the adequate content, increased false positive, parental anxiety, potential to increase the diagnostic procedure, and this requires additional genetic counseling, laboratory, and clinical expertise to support and the follow-up of the positive women. So for them, it's all cumbersome. But if it is a patient-centered, I think, so there has been rapid expansion. The question earlier when the NIPT came into the market, we used to say, can we do this? And now we are asking, should we be doing this? So the scenario changes with time. This is a case of 22q deletion, a primary gravida, low risk, 32 years old, and she was referred for me for amniocentesis because her NIPT was positive for 22q deletion syndrome, and her first trimester scan was done at 13 weeks. CRL was 61, NT was 1.1, nasal bone was normal, and first trimestral biochemical screen was intermediate risk, 1 in 675, and some obstetrician ordered the NIPT, and you can see the PAPE 0.83, P3 beta HCG. So she knew that this is on the higher side. This is just at the cutoff of 0.7. So, she ordered this, and that too with the micro deletion. The patient was lucky, and this was NIPT was positive. We did the microarray, and while doing the amniocentesis, we could see there were no any gross pathologies. And this is the baby, and those who are seeing the 22q microdeletion, they can agree that, this phase resembles the DGeorge syndrome, the commonest microdeletion syndrome with an incidence of 1 in 4,000. Then, can we do the cell-free fetal DNA in the raised NT? And in this study, 226 fetuses with NT more than 99 centile, 84 were abnormal, and 5 chromosomal abnormalities accounted for 74%. Atypical trisomy is 3%, copy number 5, Noonan syndrome 2. So they say that, so if we do only this, the cell-free fetal DNA, we can miss the 12 to 90% of the abnormalities. But the other way that we can say, if somebody, these days all the pregnancies are precious, these are IVF pregnancy, advanced maternal age. If she doesn't want to be pricked by the needle, this is also an option. We should be discussed. We should not be saying that, no, nothing can be done. So this option can be done if she denies the invasive testing. Not as a first line, but yes. Can we do the cell-free fetal DNA in the twin pregnancy? So see here, the same study by the Gill et al., and this is in the 2021, this was in the 2017. The trisomy 21, the 99.7% for the singleton, this is 99% for the twin, and the false positive rate is 0.13% for the twins, and of course the false positive rate is a bit higher, so 92.8, 97, 0.13%. And so in the twin pregnancy, the sensitivity is the same as the singleton, but just the false positive rate is higher. But to how much? It's just 0.1% only. So this is on the twin pregnancy statement, and by the Palomaki et al. And they say that the professional society's statements, 3 of the 10 statements allow or recommend cell-free fetal DNA in the twin pregnancies. Other did not address the issues, suggested the data are too sparse or recommended against it. So we feel that, the professional societies, they take some time to arrange the meetings. So actually we are doing in the clinical practice, and even in the twin pregnancy, we have identified the NIPT positive for the twin pregnancy. We did the amniocentesis, and one of them was discordant for trisomy 21. The fetal reduction was done, and that second baby was all okay. This is just to, the total NIPS we did 336 in a year, and no, not in a year, it is a data of about 3 years, and the abnormal 2 cases of trisomy 21, and they were proved by the amniocentesis. We had 2 cases of trisomy X, one was maternal and one was the fetal, 3 cases of 45X, 2 were proved, and none of the trisomy 13 were proved by the amniocentesis. So majority, as the data suggests, that trisomy 13, many of them can be confined placental mosaicism. And so it's always a dilemma for us that when the NIPT is positive, because what should we do? Should we do the CVS or the amniocentesis? Till now, before this paper came by the Norton et al. In 2022 paper, and we were doing amniocentesis only whenever the cell-free fetal DNA was positive. And after this paper, we came to understand that even the CVS is justifiable in the cases of the trisomy 21 and chromosome 18 reason. And the reason is that there is low risk of confined placental mosaicism in cases of trisomy 21, so we can still do, CVS. In trisomy 13, if the ultrasound is normal, you can do the amnio. But if the ultrasound is abnormal, of course, you need to take the action. And in all others, CVS if ultrasound is abnormal, amnio if ultrasound. So majority we are doing amniocentesis only, and if the ultrasound is abnormal, then we can do the CVS. This is a very interesting case. She was referred to me at 24 to 25 weeks of the pregnancy with the maternal Hodgkin's lymphoma, and fetal ultrasound showed FGR and hydramnios and thick placenta. And she was referred to me actually for writing that she needs termination because of the maternal condition. Then I wanted to review the paper before you put such a verdict on a paper. So I looked at her paper. NIPT has failed twice. And then as a geneticist, I could understood that she was actually having multiple aneuploidy, which is a which is a marker for the maternal malignancy. And why the NIPT was done? Because the dual marker was in the intermediate risk. Then the mother developed breathlessness and cough for the past 2-3 months into the pregnancy, and she went for the diagnosis at multiple places, but this was inconclusive, whether it is a tuberculosis, sarcoidosis. As a clinician, when there is a breathlessness, they will not think of malignancy first. So another statement, that is, should we be disclosing the incidental NIPT results suggestive of the cancer? And when I got to see this lady, I called up the lab and I asked her, did you see that multiple abnormalities? What was the reason for failure? Because nobody asked why this has failed. They went ahead, no amniocentesis, nothing. So then I asked the lab, why was the procedure failed? Because, as per the ACMG criteria, whenever there is a no-call rate, you should check with the lab. And so this is the statement from the current controversies in the prenatal diagnosis, whether the NIPT results suggesting the maternal cancer should always be disclosed. And this was a debate. And after some audience question, the voting was repeated, and the majority of the audience voted in the favor of disclosing the incidental NIPT results that suggest maternal cancer. So this gives us an insight that whenever there is a no call, call up the lab, inquire whether, that. So now all for the common aneuploidies, genome-wide NIPT, are we heading for the monogenic disorder also? Because they are also common, about 1% of the birth. And this is a clinical experience with NIPT for the single gene disorder. A total of 2,208 women received a non-invasive prenatal test for a panel of 25 monogenic disorders, of which 5% tested positive, and high test positive rate was for the pregnancies with ultrasound abnormalities, or where there was a family history of one or those disorders. So a family history is important, and ultrasound is important to guide us for the NIPT for monogenic disorders. And best part about the monogenic disorders is they are conclusive. You don't require amniocentesis or CVS to confirm, because they are diagnostic testings. This is the Australian study. So just to tell you that out of the 355 cases, 60 of the ultrasound, so the diagnostic utility of the ultrasound is very, very high compared to all these tests. So in the end, just an algorithm. We do the first trimester combined screen using PAPE and free beta HCG. And I always highlight that 1 in 250 to 1 in 1500. Somebody would use 1 in 1000. Somebody can use some different number. But for all practical purposes, because at 1500, we can include large number of women. So NIPS for chromosomal abnormalities, we do the pre-test counseling. If it is negative, then we do tell them that there is a limitations that this will not exclude the physical abnormality. So you still need an ultrasound. This will not include the monogenic disorders. But if the test is positive, we calculate the positive predictive value. There is a calculator, online calculator available, perinat.org, or you can just say that for trisomy 21, it is in the range of 50 to 75, very, very high. And we offer them amniocentesis generally, but later on, if the ultrasound is normal with the Norton paper, we have thought of that we will start doing the CVS also. So these 2-3 lines, if I have time, I'll just go through quickly. So NIPS is not a diagnosis. And the following practice points are important. That NIPT for common trisomies has the best performance by the trisomy 21. And performance for 13 and 18 is still very good, but comparable to the, and the evidence is for the singleton and also for the twin pregnancy. And NIPT for sex chromosomal abnormalities for the monosomy X is worse because of the biological factors. Expansion of NIPT beyond the common trisomies is promising. And NIPT should always be combined with a skilled ultrasound examination. Invasive prenatal testing provides diagnosis. And in the invasive prenatal diagnostic, the use of the microarray analysis and more recently the NGS has expanded the prenatal diagnostic yield by, you can say, 5 to 10% for the microarray, about 10% for the whole exome sequencing. Pre-test and post-test counseling is mandatory, and close collaboration with multidisciplinary team is urgently needed. So NIPT has changed the landscape of the prenatal screening and diagnosis. Attractive to both the patient and the clinicians, positive predictive value, non-invasive. You require a thorough pre-test counseling for the detection rate, false positive, false negative, need for invasive if positive. You require a post-test counseling for the limitations and positive predictive value if the test is positive. Thank you.
Thank you, Dr. Shima Thakur, for your excellent and exciting presentation. It was full of information, so many insights about the advanced technology. And actually, we want to curtail the burden of Down syndrome, the other chromosomal anomalies, single gene defects, and so on, because we want to reach the target of SDG. So, as she said that this NITP stands between the marker screening, biomarker screening, and invasive test. And it has its own advantages of detection rate of around 99% in case of trisomy 21, and also for other trisomies which are common for common in our population. So I think she has rightly mentioned and given a thorough insights about this advanced technology, but that is not existent in our setup, clinical setup. So may I request our senior professors are here, our President OGSP and President Fetal Medicine is here. So we want to request that we must think of this advanced technology for the better management and for prevention of the load of chromosomal anomalies in our society. Thank you, Dr. Shima, again for your lot of information and for attracting us towards this advanced technology of NIPT. Thank you so much. Now, I would like to hand over the mic to my co-chair, Professor Shahanara Appa, for next.
Thank you, Professor Fatima Ashraf. My special thank to our previous speaker, Dr. Shima Thakur. She, according to her presentation, what we have grasped that prenatal diagnostic, screening, diagnosis, and testing is become a part and parcel of prenatal care. So we, especially, though not for all, but especially for some low, medium, and high risk pregnancy, but every intervention has its own challenges. And we have to face the challenges regarding the risks of newer diagnostic modalities, the limitations, the risks, the controversies, and it is, and the last of all, the ethical issue. So may I now call upon Dr. UDP Ratnasiri from Sri Lanka. He is a consultant obstetrician and gynecology, Castle Street Hospital for Women, Colombo, Sri Lanka, and chairperson, Maternal and Fetal Medicine Committee, AOFOG, and past president, SLCOG, and past president, PSSL, and he's the treasurer of Suffolk. Dr. UDP Ratnasari, please. He will talk on the ethical issues on prenatal screening, diagnosis, and management. Ratnasari, please.
Thank you very much for your kind introduction, Chair. I think I bring greetings from Colombo, Sri Lanka. So you know that we are going to have our Silver Jubilee Suffolk in Colombo, Sri Lanka end of this month. So I expect majority of you to be there in Colombo end of this month and the early October. So my talk is ethical issues in prenatal screening, diagnosis and management. So this is something, a different topic that we are going to listen from whatever the clinical, whatever listen. So I declare that I have no conflicts of interest. So when you go to the ethics, what is ethics? Values, fairness. Here, can you please remove this? It's covering this. Thank you. So ethics are a set of concepts and principles that guide us in determining what behavior helps or harms sentient creatures. That is, what is good and what is bad, determining whatever the measures that we take. So it was described by Roosevelt Kidder. And when we know that we have screening and diagnosis of prenatal, so screening is to a population. We are using specific markers and defined screening cutoff levels. That identifies the individuals in the population at a high risk for a particular disorder. So in that high risk group, the diagnosis is different. Only screening is not enough. We have to do a diagnosis that is applied at the individual level or patient level to diagnose a disease condition. So when you are doing interventions in screening and diagnosis, these two should go together. Just with the screening procedure, we should not come to a therapeutic decision only. So in my discussion, these are their diagnosis and individual patient level. Pregnancy screening of fetal aneuploidy started in mid-1960s, now more than 40 years gone. The maternal age was the screening tool. Now over the years, you heard just NIPT, new developments have come, maternal serum, ultrasound screening, and all these have brought, and it is possible to offer all pregnant patients non-invasive prenatal testing. So that can assess the risk of having a fetus with aneuploidy and determine whether she needs an invasive prenatal diagnostic test. So screening test or the process must allow patients to decline intervention at each step throughout the process. So that is very important. So if the patient is undergoing screening test thoroughly, mother can refuse or stop that. So when you are doing a screening, there are important criteria we have to think. Screening for a disorder should be undertaken only when the disorder is considered to be serious enough to warrant intervention. And there must be both a highly accurate diagnostic test to determine whether the person with the screening positive truly has the disorder, and intervention available to all persons who are identified as being affected. It also says the markers used in the screening must be sufficiently sensitive to identify the significant proportion. At least it should be 95%, more than 95% sensitive, and identify a significant proportion of affected persons with minimal misidentification of unaffected persons. So false positive should be very minimal, and it should be less than 3%. So these are the important aspects when you are using a screening test. And it also says screen, including follow-up testing and intervention, must be available for when you are doing a screening procedure. So when you are screening, we should fulfill all these criteria before just doing a screening test. Finally, it should be acceptable to the population being screened. So those are very important aspects when you are doing a screening for a prenatal screening. So it is not only that we are doing the screening, the population who are getting screening should be informed, and information leaflets or booklets should be available to them to tell what the condition is, how common it is, and how it is diagnosed and confirmed, what treatment is available, what the outlook for the babies, and what happens next, how like to happen in the future pregnancy, where more support and information is available. So we have to have all these criteria when you are doing this kind of prenatal screening and diagnostic test. And it also should have resources and support auditing. And you have to have a good quality diagnostic laboratory service, and an ultrasound includes genetic counseling, and it should be a geneticist who is counseling, and patient and healthcare provider education, high quality testing, resources for administration. It also should have annual audit, clinical testing, and data management, and flexibility and funding to adjust the program to a new technology and protocol. So it has to cover most of these, it to be a quality screening and diagnostic procedure. Otherwise, when we are doing haphazardly the screening from our population, we may be doing harm than good for the population at large. So when you are doing the counseling for screening, it should be non-directive and must respect the woman's right to accept or decline at any of all these testing options offered at any point of the progression. And we should remember maternal age alone is a poor minimal standard for prenatal screening for aneuploidy. It should not be used as a basis for recommending invasive testing when non-invasive prenatal aneuploidy is available. Invasive prenatal diagnosis for cytogenetic analysis should not be performed without multiple marker screening results, except for women who are at risk for fetal aneuploidy. Those are the women because of ultrasound findings, because of the pregnancy was conceived by in vitro fertilization with or ITSI, or because the woman or her partner has a history of previous child or fetus with a chromosomal abnormality, or is a carrier of a chromosomal rearrangement that increases the risk of having a fetus with chromosomal abnormality. So ultrasound dating should be performed first if the menstrual or conception dating is unreliable. For abnormal all this screening, it is on the basis of menstrual dating. So ultrasound dating should be done to confirm the gestational aging before starting the test. First trimester nuchal transfers should be interpreted at risk assessment only, and it should not be offered as a screen without biochemical markers in singleton pregnancies. For women undertake first trimester screening, second trimester alpha-fetoprotein screening or ultrasound examination is recommended to screen for open neural tube defects. All these are recommendations by the College of Obstetrics and Gynecology, Society of Obstetrics and Gynecology of Canada, which has got a very good recommendation how to perform. So as you know, the screening test available. So I mentioned screening methods that meet guidelines, minimal standard of 75% detection rate and 3% of false positive rate should be applied. So most of these are tests which are mentioned in this diagram shows that it is applied for the screening test. And you see maternal age only has detection rate of 44% and false positive rate of 16%. It should not be taken. So it is very important to see the test is identifying more than 95% of this disorder, and it is only the false positives are 3% or less. We just heard about the cell-free DNA. Lowe and colleagues, they found this 1977, and it has involved and evolved over the years in diagnosis of this. And it says, although the exact technology may vary, the implications of clinical practice are the same, namely these are screening tests performed by analyzing cell-free DNA sample of maternal blood, and all positive results should be confirmed by amniocentesis or core nuclei sampling before acting upon the information. So it is very important to know that it is diagnosed properly with the other measures. So when you consider the prenatal diagnosis, that is not the screening, then we are going to do the diagnosis. So what are the aims and objectives of prenatal diagnosis? It should enable a timely or medical surgical treatment of a condition before or after birth. It should give the parents the chance to abort a patient with the diagnosed condition, and also to give parents a chance to prepare medically, psychologically, socially, and financially for a baby with a health problem or disability or for a likelihood of a stillbirth. So all these are objectives or aims when you do the prenatal diagnosis. And the diagnostic outcomes of prenatal testing can be classified for purpose of ethical discussions into the following categories. These are the lethal or severely debilitating or non-treatable malformations for which selective abortion is considered. Immediate postnatal treatment for some of these conditions are available. And intrauterine treatment, in fetal therapy is available with medications, hormones, or surgery at present. So these are also possible when you test for prenatal diagnosis. And fetal characteristics not ordinarily thought of as diseases that are either short intentionally, example, fetal test, or found incidentally, the karyotyping XYY, that may lead to a choice for selective abortion. So most correct ethical debate is focused on the latter two categories, that is treated in utero with medication or fetal characteristics not ordinarily thought of as diseases. So before beginning, we need to consider how a moral analysis of a diagnostic evaluation of the fetus might differ from analysis involving a child or adult. So we have 4. Autonomy. We have to respect in individuals' freedom to make their own decisions. Beneficence, that is acting the best interest of the individual, providing the benefit. And non-maleficence, that is avoiding or doing any harm or no harm to the individual. And we all have to see that justice is given, treating all individuals with fairness, equality, and impartiality. So these are all important in our prenatal diagnosis and therapeutic messages. So major underlying ethical motivation based on the principle of beneficence is that doing what is best for the patient is the same to identify illness so that the outcome can be improved in this. So when you consider the ethical issues, with increased detailed cytogenetic testing, there is a need to provide families. So when you provide this information, there should be a pre-test and a post-test counseling. That is before the diagnosis or after the diagnosis, what is going to happen, as well as consider the ramification for them and the fetus. So providing the mother and the family with the information regarding the pregnancy in order to promote their autonomous decision making regarding the outcome of the pregnancy, identify severely affected pregnancies that may choose to terminate with the social goal of reducing the economic and social burden of caring seriously disabled individuals. These conditions are each controversial, in part because they make interest of the fetus secondary to those of the family or society and respectively. So when you consider the ethical requirements of testing programs, laboratories and physicians of a prenatal diagnosis are required to maintain high standards for quality control in their performances of test. Should have adequately trained personnel to communicate with women before testing. Pre-test and post-test information counseling also critical because one of the outcomes of prenatal diagnosis may be the pregnancy termination. The model of genetic counseling most widely accepted is that should be non-directive counseling. The ethical basis of this model would be to be that promoting autonomous decision by making the responsibility of parties in most of these are the patients. So these are very important. So diagnostic tests should not be performed without outlining the clear plan of management, further testing that may be needed, testing a fetus with non-life-threatening condition associated with physical or mental disability such as Down syndrome. So as prenatal diagnostic techniques are used more widely there will be pressures for individual physicians to offer these tests in their offices. There is evidence that many physicians are inadequately informed about certain chromosomal abnormalities. So excessive enthusiasm for a procedure combined with inexperience can be very dangerous. So there is a very high ethical mandate to centralize the testing when appropriate and to provide vigorous training for individual physicians who choose to provide testing in their offices. So it is very important to follow this if you are applying screening and treatment procedures. So ethical justification for a policy of providing subsidized prenatal testing would rest primarily on the justice requirement that fetuses with equal risk of a problem should not be denied, especially the financial means of their parents. So if you have this testing, the priority should be given to the treatment in utero problems. These are more cost effective and therefore should be the priority. So it is less certain whether the society has an obligation to provide diagnostic testing for disorders for which there is no treatment, so that the selective abortion becomes the only treatment option. And it seems clearly not appropriate when the characteristics of interest is not considered as an illness. So recommendations to women about the performance of prenatal testing must be modified clearly by the category of for the research purpose or non-research purpose. No patient should be forced to undergo diagnostic that is not considered to be the standard practice. So you have unique aspects of prenatal diagnosis. They are the moral status of the fetus, the use of selective pregnancy termination, the need for bodily participation of the mother in the performance of procedures, the need for the use of proxy decisions markers of the fetus. So when you consider the moral status of the fetus, women become bonded to their unborn children very early in the pregnancy to be of the opportunity of view them when we view them with the ultrasound. So gestational age probably is the most commonly considered significant in terms of concept of viability. The most famous definition of viability was provided in legal opinion Roe and Wade. It delineates the acceptability of abortion on demand based on the distinction. Many would agree that late third trimester fetus requires more consideration than a 6-week embryo. Recently, in Texas, adopted a law that effectively banned almost all abortions beyond the time at which the fetal cardiac activity, a fetal heartbeat, can be detected or about the 6th week of pregnancy. The law was, unlike several other fetal heartbeat status passed in other states, in that it shifted responsibility for enforcing ban from state officials to private citizens. So what is required for a fetus to be considered as a human? So Chenoweth, he mentioned that argued an encephalic fetus has no independent human moral status, that pregnancy termination of an encephalic fetus should be allowed at any gestational age. Pregnancy termination as prenatal treatment appears to be the only type of medical diagnosis in which a possible outcome is intentional death. The relative unacceptability of euthanasia in the case of fetus as compared with the rejection of that same procedure who chosen by a competent adult. So the risk that physicians may lose their commitment to true therapeutics when you do terminations of pregnancies for fetal anomalies, technically easier practice prenatal diagnosis and selective abortions. In addition, concern is that while abortion may continue to be a morally justifiable choice for serious untreatable fetal anomalies, some women with positive screening test results may choose elective abortion rather than going for definitive workup. So what is the participation of the mother in this prenatal? The issue of maternal rights versus fetal rights is perhaps the single most difficult issue in the arena of prenatal diagnosis. A woman's being required to undergo a test that involves invasion of her body if she does not consent to the performance of that procedure. For a competent non-pregnant woman, the answer is generally no. So when you consider three possible relationships between pregnant woman, the fetus, and the obstetrician that may lead to different management choices, gynecological, you can consider only the mother is considered the patient. And interventions for the fetus only occur if agreed by the mother. The pediatrics, the fetus is the primary patient. The therapy is evaluated only as it affects the fetus, and abortion is never an option. The obstetrical part is the fetus is provisional patient and is treated only as long as it and its mother have a shared interest in continued the treatment. So these are important when you consider the pregnancy. The obstetrical contract, which may fit the best with current practice, has the goal the production of a healthy newborn or just the survival of the fetus at any cost, as suggested by the pediatric contract, and unlike gynecological contract, not regarded as the maternal autonomy as absolute. The basic ethical dilemma is the conflict between the respect in maternal autonomy versus acting beneficently towards the fetus. So these are very important aspects when we consider prenatal diagnosis. With regard to the process of obtaining informed consent, when the pregnant woman is reluctant or unwilling to consent, the statement says this is obtained from the American College of Obstetricians and Gynecologists, the Committee of Ethics. Actions of coercions to obtain informed consent or force, a cause of action limiting maternal freedom of choice, threaten the doctor-patient relationship, and violate the principles underlying informed consent process. So these are important aspects. Now, you all know fetal therapy is available, intrauterine fetal therapy, and the ethical considerations when you consider American College, the Academy of Pediatrics, in 1988 statement of states that physicians should recommend to the pregnant woman those fetal interventions that have demonstrated efficacy and do not pose serious threat to the health of the woman. Fetal therapy suggests that physicians may even be obliged to point out women's obligations to accept some personal risk for the benefit of the fetus. However, should the woman refuse to undergo an intervention that poses a personal risk, her autonomous choice should be generally respected. So, in fetal therapy, following three criteria to be ethically permissible. It should be a life-saving or should prevent or substantially mitigate serious or irreversible disease, injury, or handicap to the fetus or the child to be. The proposed therapy should have low mortality risk for the fetus and low or manageable risk of a serious disease, injury, or handicap to the fetus or born child. The maternal mortality and morbidity or disease or injury or handicap risk to the mother should be very low or manageable. So when you do the fetal therapy, maternal morbidity and mortality also should be considered. So potential risk and evolutionary morbidities in case of therapeutic failure should be part of the counseling for fetal therapy. Neither should fetal therapy be presented as an alternative to the termination of pregnancy. All these are under a limited set of circumstances. It may be appropriate for the patient to oppose a woman's refusal to consent for fetal intervention. These are when there is a substantial likelihood that the fetus will suffer irreversible harm without the intervention. When the intervention is clearly appropriate and will like to be efficacious, and when the risk to the mother is very low, the statement reads, court intervention should be seen as the last resort to be undertaken when great caution because the consequence of forced medical or surgical procedures. So these are all found in the American Academy of Pediatrics when you are doing a fetal therapy. And the proxy decision making. It is obvious that the fetus cannot take autonomous decisions. Although the situation is complicated by the need to take into account the wishes of the mother about her own baby, the issue of decision making of the fetus should be considered separately. Two main and mutually exclusive ethical guidelines have been used as a basis for proxy decision making. Those are consideration of the best interest of the incompetent one, that is the baby, the beneficence-based rule, or the determination about what the incompetence one would want done, substitute judgment. So these are many fetal abnormalities remain untreatable in utero. Would a fetus even choose selective abortion? And if we think it would, under what conditions would it like to do so? What are the best interests of the fetus in the situation of a male fetus at 50% risk of inheriting hemophilia? So when a treatment procedure has developed, but it is not yet considered standard practice, how a physician and parents decide whether or not to try it? So it says the most important criteria is the expected treatment outcome. If the outcome is expected to be good, then the treatment should be recommended. If the treatment outcome is uncertain, then the patient's decision should be the final one, parents actually. And if the treatment outcome is predicted to be poor, then the recommendation to pursue the treatment can be made, and further, the patient can refuse to provide even if against the parent's wishes. For use in determining the advisability of fetal treatment, using this policy, if a prenatal diagnostic test is expected to be accurate in the diagnosis of the disease with serious morbidity for which relatively effective treatment is available, then the physician should strongly recommend the test. On the other hand, if the diagnostic procedure is not very accurate or there is no treatment for the disorder, then there should be little ethical basis for the strongly recommending that it should be used. So these are all. The patient has a serious doubt about the capacity of the mother to take decisions. Several options are available. If the question is one of the legal competency, appropriate legal steps to appoint a guardian should be made. If a psychiatric condition is thought to exist, consultation should be obtained with the psychiatrist. How should we consider rights of a normal fetus as in view of the risk to them that be present with any in utero intervention? Who will be the best advocate? So ethical and practical issues, the option to continue abort pregnancy is the choice after most prenatal testing. Are the risks of prenatal diagnosis such as amniocentesis worth the potential benefit, knowing that certain birth defects such as spina bifida, teratoma before birth may give the option of fetal surgery during pregnancy, or assure that the appropriate treatment and surgery be provided immediately after birth. Questions of value of mentality of physically disabled people in the society. How to ensure that information testing options is given in a non-directive and supportive way, that the parents are well informed if they have to consider abortion versus continuing pregnancy. So will the results of tests affect the treatment of the fetus? Some genetic conditions like cystic fibrosis and abnormality can be only detected with DNA is obtained from the fetus. Usually an invasive method is needed to do this. An early diagnosis gives the parents time to research and discuss the postnatal treatment and care, in some cases, sometimes abortion. Genetic counselors are usually called upon to help families make informed decisions regarding results of prenatal diagnosis. False positives and negatives. No perinatal test can detect all forms of birth defects and abnormalities. So informed consent is important in medical practice. Obstetricians have an ethical duty to properly inform patients of their options, especially the availability of screening and diagnostic testing. Physicians have been successfully sued by women who gave birth to babies with abnormalities that could have been detected had they known about their screening options. Also, the other way, physicians also fail to inform their patients of the risk of amniocentesis, and CVS might be found guilty of negligence of informed consent in the event that the patient sues after procedure-related miscarriage or fetal damage. So all these aspects we have to consider in prenatal screening and diagnosis and therapeutic fetal therapy as ethical considerations. Are we considering all this, or are we just leaving and doing this screening without all whatever ethically fulfilling the criteria for our pregnant women and the nation? Thank you very much for listening, and I hope that this just not a clinical, but mostly the ethical issues in prenatal diagnosis. Thank you very much.
Thank you very much, Dr. Ratna Siri, for wonderful presentation and time-demanding topic, but unfortunately neglected and very poorly addressed. We have learned that every testing, whether it is prenatal or postnatal or any testing, it has some ethical issues, ethical general issues of any diagnostic test, like predictive value of this particular test, or whether it has been counseled before any asking for any test, and what is the outcome of that test, what is the implication of this test after getting the diagnosis, and maintaining of the privacy, confidentiality, all are related to a particular diagnostic test. It is one hand, and what we have also learned that every test has also some other implications, like to impose in that particular index pregnancy. So it is what we will do with that index pregnancy if anything has come out after prenatal diagnosis. He has rightly discussed that many issues are there, whether we can cope up with this diagnosis. There are so many issues, like we can abort the fetus if it is uncompatible to life. If it is not uncompatible to life, but it has only neurological handicap like Down syndrome, what to do? How to take this decision? And another important ethical issue he raised, that is, if a preliminary screening test become positive for a particular chromosomal or genetic defect, many of the parents might not willing to undergo the diagnostic testing. So there is also an ethical issue, and how to deal with those outcome of the diagnosis, how far we can do, and what is the cost involved, what is the evidence involved. At the same time, mother and fetus, dual decision, we are talking about autonomy. We should give the information to the parents, especially the mother, to take bold decision by herself. But what about the beneficiaries? Because the fetus is yet to be born. These are all issues, and final issue is related to physician, non-maleficence, and we are in the dilemma. So every new test has its limitation. We have to give pre-test information to the couple, as well as post-test information and guidelines, and what to do and where to refer. So all those together can minimize the ethical issue related to prenatal testing, screening, and diagnosis. Thank you very much. Thank you.
Thank you, Chairpersons Madam, for conducting the sessions very successfully, and respected speaker for your excellent deliberation. Now I would like to request our Chairperson Madam, Professor Fatima Ashraf, to give certificate of appreciation to our speaker, Dr. Shima Thakur. My humble request to Chairperson Professor Shahnara Chaudhary Madam to give certificate of appreciation to Dr. UDP Ratnasiri Sir. Now I am requesting Professor Fatima Ashraf Madam to give a newly published book written by our beloved Professor Firoza Begum Madam on high-risk pregnancy for postgraduate students by JP Publications to Professor Shahnara Chaudhary Madam. And I also requesting Professor Shahna Chaudhary Madam to hand over the book to Professor Fatima Ashraf Madam. And we are now at the end of the session. Our next session will be sharp at 11:30 a.m. and it is our plenary session, and our sir will join us in the online And please, we are requesting all the delegates to come back in this hall at sharp 11:30 a.m. Thank you for your kind participation.